Again, my name's Amy, and I come to you today I work primarily out of the medical ICU at New York Presbyterian Hospital in New York and Manhattan. Okay, I have nothing to disclose. And for the next 45 minutes, what we'll talk about are key components of ICU medicine that can be applied to all critically ill patients. We'll also talk about therapeutic options for stress ulcer and DVT prophylaxis, followed by discussing therapeutic options for patients with heparin-induced thrombocytopenia, and then discuss medications that can be used to provide comfort in a critically ill patient at the end of their life. So first, we'll start off with those important aspects of critical care medicine that can be applied to all of our patients. And this is often referred to as the fast hug mnemonic. This mnemonic really emphasizes important aspects of ICU medicine that can be applied daily to our ICU patients. It also provides some structure in an effort to efforts to decrease errors of admission while improving compliance with evidence-based practices. Looking a little bit closer at what the mnemonic entails, first includes feeding, and that's important to initiate feeding as soon as possible, and certainly enteral over parenteral feeding. Providing appropriate analgesia and sedation, and using a validated tool while providing light levels of sedation, and executing a sedative interruption when appropriate. Also initiating appropriate prophylaxis for DVTs while weighing the risks of bleeding. Ensuring that the patient's head is elevated about 30 to 45 degrees above the bed, and assessing that throughout the day as we conduct a lot of procedures in our patients where the patient's up laying flat. And so ensuring we have methods in place to making sure that head is elevated is to potentially decrease the risk for aspiration. Considering acid suppressive therapy in patients who are at the highest risk, but once those risk factors are no longer present, to appropriately discontinue the medication, and then also appropriately providing glycemic control. So that brings us to our first patient case, who is a 68-year-old man intubated and admitted to the ICU for pneumonia. His current medications include antimicrobial agents. He's also on a fentanyl infusion and midazolam infusion, which is titrated to a Richmond agitation sedation score of 0 to -1. He has been appropriately started on an insulin drip. He has DVT prophylaxis, which is sub-Q heparin. Currently, the patient's head is 30 degrees above the bed. His RAS is documented to be a -4. He's on minimal ventilator settings, and he has an NG tube. So which are the best recommendations to make to the team at this point? Initiate enteral nutrition, add stress ulcer prophylaxis, and discontinue the midazolam and fentanyl. Initiate enteral nutrition, discontinue DVT prophylaxis, and transition that insulin infusion to a sliding scale. Transition insulin to a sliding scale, add stress ulcer prophylaxis, and discontinue the fentanyl and midazolam. Or discontinue fentanyl, midazolam, discontinue DVT prophylaxis, and add stress ulcer prophylaxis. Okay, great. The majority did get answer number 1, which would be to appropriately initiate enteral nutrition. Now, some of you may say plus or minus these on minimal vent settings. You might be doing daily spontaneous breathing trials, but it is important to still, when not doing that, appropriately feed our patients. He is still mechanically ventilated, so does warrant some stress ulcer prophylaxis. And because his RAS is documented at -4, we would want to ensure that we're maintaining our goal of 0 to -1, and so stopping the infusions and letting the patient wake up. So next we'll talk about stress ulcer prophylaxis. Superficial mucosal damage occurs in almost all of our ICU patients and occurs very early on within the course of their ICU stay, and it's been documented to start at about 24 hours after ICU admission. Despite this high rate of mucosal damage, very few patients will go on to develop clinically significant bleeding. Patients who do develop stress-related bleeding, though, the mortality ranges between 50 and 70%. And it's important to understand that these patients don't die from the bleeding itself. These patients oftentimes succumb to multi-organ system failure and sepsis. Now, stress ulcers are very different from peptic ulcers. Stress ulcers are developing in a specific clinical setting. They tend to be acute, multiple superficial lesions that are in the proximal stomach bulb. And this is very different from peptic ulcers, which tend to be more chronic in nature, single deep lesions in the duodenum. Oftentimes, if patients with peptic ulcer disease go on to bleed, they need endoscopic therapy. Whereas patients with stress ulcers, they will heal over time without intervention as the patient's clinical status improves. The pathophysiology of GI bleeding as it relates to the stress-related mucosal damage is multifactorial, and in fact, this pathway is not very well understood. We think the primary mechanism, though, is a decrease in splanchnic perfusion, and that leads to the gastrointestinal bleeding. However, there are a number of other factors in the gray boxes that may contribute, and some of these include impaired defense mechanisms, where you see an increase in acid-back diffusion, or a decrease in those protective factors, such as the bicarbonate or prostaglandin production. Some disease states may lead to an increase in acid secretion, and other patients may suffer from reperfusion injury, inflammation, or free radical formation. Now, it's important to define what constitutes a clinically significant bleeding and differentiate that from other types of bleeding that may not be so detrimental to our patients. So as mentioned before, many of our patients in the ICU will have endoscopically evident mucosal damage, but they may not be causing harm to our patients. Up to 50% of ICU patients will experience occult bleeding. Then we get to more severe bleeding, such as overt or clinically evident bleeding, which occurs in 25% of our bleeding. And most importantly, clinically significant bleeding occurs between 1% and 5%. Now, if you look historically back in the late 1970s to the mid-1980s, clinically significant bleeding was as high as 15%. But as the decades have gone by, we've seen a decrease in this incidence, and that's primarily because of our improved resuscitative efforts, as well as the use of stress ulcer prophylaxis. So taking a closer look at those bleeding definitions, clinically evident bleeding it can be defined as presence of coffee grounds in nasogastric aspirate, guaiac-positive nasogastric or guaiac-positive stools, hematemesis, melena, or hematochezia. Whereas you look at clinically significant bleeding, that constitutes bleeding plus either hemodynamic changes because of a decrease in hemoglobin or a hemoglobin drop that requires transfusions. When thinking about initiating stress ulcer prophylaxis, it's important to identify those patients who are at increased risk, then identifying what agent will be used at what dose and what route, all the while minimizing any acid-suppressive adverse reactions. And then finally, once those risk factors are no longer present, to appropriately discontinue the therapy. This was a trial conducted by the Canadian Clinical Trials Group in efforts to identify what are the important risk factors for patients going on to develop clinically significant bleeding. This trial looked at over 2,000 patients who had moderate to severe illness admitted to either medical or surgical ICUs. The authors identified two independent risk factors for clinically significant bleeding, and those were defined as respiratory failure, which was the requiring of mechanical ventilation of 48 hours or more, or coagulopathy, which was defined as an INR of less than 1.5, platelets of less than 50,000, or a PTT 2 times the normal. Out of the 847 patients that had one or more of these risk factors, it was found that these patients had 3.7% of patients went on to develop a clinically significant bleed, whereas the other 1,400 patients enrolled in the trial that had neither one of these risk factors, there was a 0.1% rate of bleeding risk. So really you can conclude from this trial that the patients who are at highest risk having respiratory failure or a coagulopathy should be initiated on stress ulcer prophylaxis, where if those risk factors are not present, you have a very, very low chance of that patient developing clinically significant bleeding. Subsequent trials have gone on to identify other risk factors in our critically ill patients that are mechanically ventilated. And you can see from this long list that respiratory failure and coagulopathy still make the list. And other risk factors that should be highlighted include acute kidney injury, patients with myocardial infarction, neurologic injury, sepsis, shock, and those suffering from acute or chronic hepatic failure. The routine use of gastric pH monitoring is not standard of care. However, some clinicians will practice that way, and it is certainly conducted in some research. Evidence shows that to prevent stress-related mucosal damage, a gastric pH should be maintained around 3.5 to 4.5. Now, how long throughout the day that pH needs to maintain in that range still remains elusive. And that really is in direct contrast to a pH of around 7, which should be maintained once somebody does have clinically significant bleeding. For a gastric pH of around 7 does promote more of that wound healing. So here lists the pharmacological therapy that can be used to prevent stress ulcers. So first on this list, we have antacids. And today, antacids have really fallen out of favor for the use of stress ulcer prophylaxis for a number of different reasons. One is their effectiveness really plummets as time goes on. You develop tachyphylaxis, which then results in a very intensive dosing regimen, often every 3 hours to 4 hours. When administering antacids with concomitant medications, you have to deal with interactions, a lot of binding. You also are giving patients perhaps a number of electrolytes. With patients who are suffering with acute kidney injury, those electrolytes may accumulate, leading to more harm. And also, this is only creating a dose-dependent neutralization of acid, so you're not affecting the acid. So in order to achieve that gastric pH of around 3.5 to 4.5 might be quite difficult with antacids. The next is sucralfate, which complexes with fibrin and albumin to form a viscous complex, which really coats the ulcer in the setting of a pH of around 4 and protects that ulcer from the acidic environment of the stomach. However, I'm going to show you in the next slide that the effectiveness of sucralfate has been in question with clinical trials, as well as it does have a relatively intense dosing schedule of Q6 hours. And again, those binding issues are still present with sucralfate. Additionally, some clinicians are concerned, especially in patients with acute kidney injury, of the accumulation of aluminum from the sucralfate, which could lead to altered mental status. So finally, we're left with the histamine type 2 receptor antagonists and the proton pump inhibitors, which are really two agents that will decrease acid secretion and not just neutralize the acid. So again, from the Canadian Clinical Trials Group, we have this study which compared sucralfate to H2 blockers, enrolling 1,200 mechanically ventilated ICU patients. Patients were randomized to receive sucralfate orally or ranitidine as intermittent dosing. And you can see here from the chart along the y-axis, you have percent of patients, and they found that patients who received sucralfate had a higher rate of clinically significant bleeding as compared to ranitidine. Now, it's important here to just take a moment and recognize that the authors defined clinically significant bleeding as what is in line of how it would normally be defined, and that it was a drop in hemoglobin that would require transfusion, or patients had hemodynamic compromise. So a very traditional way to define clinically significant bleeding. Now, comparing the H2RAs to the proton pump inhibitors, there are several trials. I just want to highlight two that are mostly quoted in the literature. The first was a randomized, double-blind, non-inferiority trial, including about 400 mechanically ventilated ICU patients. Patients were randomized to receive cimetidine as a bolus dose followed by a continuous infusion, which, by the way, is the only H2RA which is FDA approved at this dose for stress ulcer prophylaxis, and compared that to oral omeprazole daily. Here, the authors define clinically significant bleeding as simply bloody gastric lavage, which is not consistent with how you would define clinically significant bleeding. However, there was no difference between the omeprazole group or the cimetidine group. When the authors then looked secondary at any types of bleeding, they saw significant increases with the cimetidine group. But again, the authors are often criticized as using non-traditional definitions for the bleeding or any type of clinically significant bleeding. Another trial randomized 67 mechanically ventilated patients, and patients were randomized to either ranitidine as a continuous infusion or intermittent dosing. versus a simplified omeprazole solution once daily. Here again, the authors used a more streamlined definition of clinically significant bleeding and found that there was a significant difference between ranitidine and the omeprazole solution. However, just take a moment and look at that baseline bleeding rate with ranitidine, and that really is not in line with the baseline bleeding rates that we would expect. That's much, much higher. And despite randomization in this trial, those patients who were randomized to the ranitidine group tended to have significantly more risk factors than those that were in the omeprazole group. So the authors do get criticized that quite frequently. So there are a number of meta-analyses that are out there comparing the H2RAs versus the PPIs, and they tend to all favor the PPIs over H2RAs in terms of clinically significant bleeding. But when looking at those meta-analyses, as I've pointed out already, a number of the studies that are included lack methodological quality with unexpectedly high rates of baseline bleeding, a disproportionate number of risk factors between the patient groups, inconsistent definitions of bleeding, and different routes of dosing of the agents. So from there, I just want to take a moment and point out some of the potential complications of PPIs. Now, some of them may not be applicable to our ICU patients, as some of these are more long-term, including interstitial nephritis or some electrolyte abnormalities such as hypomagnesemia, which is seen at about 3 months of therapy. Neurologic effects have been seen with high doses of IV omeprazole. If using the bicarbonate solution to give these agents down the NG tube, you might see hypophosphatemia and a metabolic alkalosis. And then again, another long-term risk might be the increased risk for fractures. However, what might be interesting to us as ICU clinicians is the infection risks with the PPIs, including C. diff and the risk of nosocomial pneumonia. Now, it makes sense. As you increase the gastric pH, that's going to promote bacterial overgrowth. And when you specifically look at the PPIs and their mechanism, they're inhibiting acid at the final common pathway. And so they have the ability to maintain a sustained higher pH and perhaps increase the risk for these infectious complications. Meta-analyses have demonstrated lower pneumonia rates with sucralfate compared to H2RAs, and that should make sense because sucralfate's not altering any gastric acid where H2RAs are. However, when you compare the two agents, H2RAs and PPIs, both affecting and changing gastric acid secretion, there tends to be no difference. However, I do want to point out that most recently, there was a very large pharmacoeconomic study that was done, including around 35,000 patients, that found the incidence of pneumonia was higher with PPIs as compared to H2RAs, and that is the largest cohort study that we have today, suggesting there might be the increased risk with PPIs. In terms of C. diff, there are a number of different trials. A lot of these are not in our ICU patients. One I would just like to point out was an interesting cohort study that found the risk of Clostridium difficile increased as you increased your acid suppressive therapy. So looking at an odds ratio of 1 with no acid suppression, and that increases to almost 2.4 as you increase the frequency of PPI administration. Again, quoting that pharmacoepidemiological cohort study, found rates of C. diff were significantly higher with PPIs over H2RAs. And these are ICU mechanically ventilated patients, so this is the closest thing that we have to identify these perhaps increased risk of infectious complications in our ICU patients. It should be noted, though, when looking at the C. diff studies, many of these trials have different definitions of C. diff. There is an unclear association of the initiation of the acid suppressive therapies and when C. diff is diagnosed. And there might be variable infection control practices, although a lot of the trials do not report out on those. So unfortunately, the true association between acid suppressive therapy and the true risk of these infectious complications can be debatable, as a causal relationship has not been well defined. However, there are a number of studies to suggest that perhaps there is the potential risk for these complications with PPIs, and so prudent use of this class of medications may be warranted to decrease the risk if one potentially exists. We have a number of guidelines which provide some recommendations. Dating back to 1999, you have the American Society of Health System Pharmacists, which really leave the decision up to the institution on which agent to use and which will be best. However, subsequent to 1999, there have been many other studies published since then, and so these recommendations might not be applicable today. In 2008, there was the Eastern Association for Surgery of Trauma, which recommended cytoprotective agents such as misoprostol, and then H2RAs or PPIs, but firmly recommended to abandon the use of antacids. We had the 2012 Surviving Sepsis Guidelines, which preferred PPIs over H2RAs, and in 2014, the Danish Society of ICU Medicine made the same recommendation. And we eagerly await the SCCM, ACCM guidelines on stress ulcer prophylaxis and their recommendations. So moving on to our second case, we have a 45-year-old woman who's intubated and admitted to the ICU with pneumonia. She's currently receiving fluid boluses, norepinephrine, and vasopressin infusions, and appropriate antimicrobial therapy. You can see here she has an elevated white count. Her platelets are 45,000. She has an elevated BUN and serum creatinine, which is elevated from baseline, and she has a little bit elevation in her liver enzymes. So at this point, which best reflects the patient's number of risk factors for stress-related bleeding? So you had to do some quick counting there. So we have actually 4 risk factors evident. This patient was mechanically ventilated. She has a coagulopathy. She has shock and she's on pressors. And gosh, I have to go back to the case to remember the 4th one. But there were 4 risk factors evident in this patient case. And so perhaps the additive of each risk factor may also increase the patient's risk for bleeding as well. So which would be the most appropriate to prevent stress-related bleeding in this patient? Okay, a lot of you are still going to use PPIs. So this, I did give you a hint that this patient did have an NG tube, so you may choose to use something orally. However, I think if given the information that we have, we don't feel that H2RAs or PPIs have greater effectiveness over one another, but I think weighing perhaps some of the infectious complications and other long-term complications, most people would tend to use H2RAs over PPIs. Now, some of you might be struggling with, but the guidelines say PPIs, and I think, again, everything's pushing towards H2RAs in this case. Okay, so 1 week later, the patient's respiratory status has greatly improved. She is extubated off sedation and vasopressors and working with physical therapy. She's still on some antibiotics, DVT prophylaxis, and stress ulcer prophylaxis. Her labs have vastly improved. Her white count's down. Her platelets are back up. Her serum creatinine is closer to baseline, and her liver enzymes are recovering. So which would be the most appropriate recommendation to make to this patient's stress ulcer prophylaxis regimen? One, should you continue until hospital discharge, continue until ICU discharge, it should be discontinued now, or continue until the patient is off of antimicrobials? Excellent. So everybody wants to discontinue it. So all her risk factors, including now she is extubated, her renal function has improved, her platelets have come up, and all of that has resolved. So there's no need for this patient to continue stress ulcer prophylaxis. So now moving on to deep vein thrombosis prophylaxis. So the actual incidence of DVT is very hard to ascertain in our critically ill patient population. When you look at the literature, it ranges anywhere from 10 to 80%. And this is problematic because when you look at the studies, there is a very heterogeneous group of patients. They lack equal methodology, and especially the diagnosis of DVTs is very different from one study to the other. However, we can make some approximations. In the absence of prophylaxis, the risk of DVT development is about 30% in our medical surgical patients, up to 60% in trauma patients, and up to 80% in orthopedic surgical patients. In neurosurgical populations, again, there's that wide range between 20 and 50%. There was a recent randomized controlled trial in medical surgical ICU patients demonstrating that the rate of new onset DVT was only about 5 to 6% when pharmacological prophylaxis was used. So looking at the 30% in the absence of prophylaxis, we can really impact the rate of new onset DVT by simply applying appropriate DVT prophylaxis in our patients. There are a number of risk factors for the development of DVT. They can really be clumped into two buckets, those that are general medical and those that are ICU required. Suffice it to say that our critically ill ICU patients probably have one, if not more, of these risk factors present upon admission to the ICU. In terms of preventing DVT, it's recommended to use pharmacological prophylaxis with either low-dose unfractionated heparin or low molecular weight heparin. However, if the patient is bleeding or has an increased risk for bleeding, it is appropriate to use mechanical prophylaxis. But again, reassessing that patient daily for once those risk factors for bleeding are no longer present to appropriately apply pharmacological prophylaxis. There are two types of mechanical prophylaxis that includes the intermittent pneumatic compression devices and the graduated stockings. When looking at studies comparing mechanical prophylaxis versus no prophylaxis, we see a significant reduction in the incidence of DVT. In fact, there was a recent Cochrane review which evaluated the results of 19 studies using graduated compression stockings. And again, you see the new onset DVT rate of about 9% when mechanical prophylaxis is used, with 21% in the control group. And the same reduction was also found for new onset or suspected PE. So again, if a patient cannot receive pharmacological prophylaxis, it would be prudent to use mechanical prophylaxis if appropriate, as long as patients don't have breaks or other reasons why they can't get mechanical prophylaxis. One limitation to these trials is that this is largely taken from the surgical population, so the use of mechanical prophylaxis in our medical patients is extrapolated from this data, and we have very little data in our medical patients. There are a number of pharmacological agents, as mentioned, that can be used. The two low molecular weight heparins that have been studied include enoxaparin or dalteparin. However, the use of these agents might be limited in certain patients that are suffering from acute kidney injury, as they are largely dependent on renal function for elimination. Recently, there was a trial looking at dalteparin use in patients with lower creatinine clearance of around 20 to 30, and those patients, there was found, the authors found no accumulation of the drug and no increased rate for bleeding. If, though, the patient is at increased rate for bleeding or the patient is suffering from AKI, alternatively, unfractionated heparin can be used at either dosing it twice a day or 3 times a day. Most of the literature, the large randomized controlled trials, center around evaluating the twice-daily regimen of unfractionated heparin, and there are no direct comparisons to the twice or thrice-daily regimen. Some indirect comparisons can be made from meta-analysis that have concluded that using the twice-a-day or 3 times a day dosing doesn't change your rate of DVTs and does not change the rate of bleeding. So really, I'll leave that up to your institution, whether you weigh the risks of thrombosis or bleeding, whether or not you use 3 times or twice a day dosing. Fondaparinux also can be used for DVT prophylaxis. However, again, in patients with reduced creatinine clearance, it is contraindicated because it is largely dependent on the kidneys for elimination. There are some cohort studies that have looked at using a reduced dose of fondaparinux, but again, maybe not the most optimal agent in our patients, especially at increased risk for bleeding. It does have a longer half-life, and so if that patient bleeds, there's no reversal agents as well. So comparing unfractionated heparin to dalteparin, there was a large multi-center randomized trial comparing twice-a-day unfractionated heparin to dalteparin in almost 3,700 adult medical surgical patients. The primary endpoint of this study was looking at new onset DVT after 3 days of randomization. They found equal rates between the two, so about 5% new onset DVT between both groups, so one agent did not turn out to be better than the other in this case. Secondary endpoints look at definitive or probable PE, where they saw significantly lower rates of PE in the dalteparin group. However, that was a secondary outcome. And when looking at major bleeding between the two agents, again, you saw about 5 to 6% in both groups. So again, kind of the first trial to really compare these two regimens together, and they seem to be equally effective. Some considerations in our critically ill patients perhaps who are on high-dose vasopressors or have significant edema, we're administering DVT prophylaxis subcutaneously, and so perhaps there might be a reduction in bioavailability and a reduction in effectiveness in some of these severely critically ill patients. Renal impairment is still a concern, especially when using low molecular weight heparins or fondaparinux, but again, referring back to that one small trial which looked at patients with reduced creatinine clearance receiving dalteparin, there seemed to be no accumulation or no increased risk for bleeding. And then, of course, what do we do with our bleeding patients? Again, I have suggested that temporarily using mechanical prophylaxis until the bleeding risk abates. However, largely these patients are excluded from a lot of these trials, so to make real good recommendations is really hard with this patient class. In terms of the novel oral anticoagulants, there are no studies to date in our ICU patients for DVT prophylaxis. I would just like to highlight one trial that was conducted in acutely ill hospitalized patients that randomized patients to rivaroxaban as compared to enoxaparin for DVT prophylaxis. The rates of composite endpoint, this was their primary outcome, was asymptomatic or symptomatic VTE, pulmonary embolism, or death, was not different between the two groups and was statistically significant to meet non-inferiority of rivaroxaban. However, when looking at clinically evident bleeding, there was an increased rate of bleeding in the rivaroxaban group compared to the enoxaparin group. So again, something to take into consideration in our very acutely ill patients that are perhaps at increased risk for bleeding. So now our third patient case, we have a 93-year-old bedbound man who is admitted with a COPD exacerbation requiring mechanical ventilation. He has a history of diabetes and heart failure, and his lab values are within normal limits, except he is suffering from acute kidney injury. So which would be the most appropriate recommendation for VTE prophylaxis in this patient? Okay, great. So the majority of you chose to use unfractionated heparin at twice daily dosing, and that's probably at this point the best option to use. This patient is suffering from acute kidney injury, so using the agents that are dependent on renal function for elimination, such as enoxaparin or fondaparinux, might not be the most optimal at this time until we can assess where that patient's renal function is going. Okay, and next we'll talk about heparin-induced thrombocytopenia. It is a rare but severe immune-mediated reaction that can potentially lead to life-threatening complications. And these complications really arise from both venous and arterial thrombosis. These patients are essentially left in a hypercoagulable state when they have heparin-induced thrombocytopenia. It's difficult to define the true incidence of HIT in our critically ill patients, for as thrombocytopenia is one of the most common laboratory abnormalities found in our hospitalized and critically ill patients. However, serologically proven HIT occurs in about 1 to 3% of patients with heparin exposure. And that risk of HIT increases with the type of patient population that you're talking about. So we might see a risk of about 1 to 5% in our high-risk cardiac and orthopedic surgical patients, where it drops in our medical population to about 0.1 to 1%. The diagnosis of HIT should be made based on clinical observation as well as laboratory testing. From a clinical perspective, you will see an absolute platelet count drop below 150,000 or a relative decline 50% or more from baseline. Now, it's also important to look at the timing of when the platelets have dropped. Typically, you'll see them drop about 5 to 10 days after heparin exposure. However, some patients may have a more rapid decline in their platelets of about 24 hours or less, and those are going to be patients who had some sort of heparin exposure and who already have developed antibodies. And if you look at the literature, the exposure is thought to be about that 100-day mark. So if you see somebody who has a rapid decline in platelets who you've given heparin to, you want to make sure you get a good past medical history to see if that heparin was exposed, if the patient was exposed to heparin in the past 100 days. There's also delayed onset HIT, which can occur up to 3 weeks after the cessation of any type of heparin therapy. And as mentioned before, HIT can be complicated with thrombosis, and that can be venous or arterial. The different types of laboratory testing for HIT include an antigen assay, which detects the presence of antibodies against the platelet factor IV heparin complex. These types of assays have a high sensitivity but a moderate specificity, as it will pick up non-pathogenic antibodies as well. However, the antigen testing is more readily available. The turnaround time is relatively quick in most institutions, so this tends to be the first laboratory test that gets sent off to help with the clinical diagnosis. There are also functional assays which look at the platelet aggregation in the presence of heparin. These assays are highly sensitive and very specific. In fact, the serotonin release assay, which is one of our functional tests, is considered the gold standard for diagnosing HIT. However, these can be quite technologically challenging and not readily available, and oftentimes they're send out, so the turnaround times can be about 5 to 7 days. So if you have a clinical suspicion of HIT and you're sending off that laboratory data, it's very important to make sure if you have a high suspicion, you're initiating treatment and not waiting for those laboratory tests to come back. The treatment of HIT includes immediate discontinuation of all sources of heparin and initiating alternative anticoagulation with either a parenteral direct thrombin inhibitor or a factor Xa inhibitor. Now, once the patient has equilibrated their platelets, they're above 150, or they've received 5 days of this alternative anticoagulation, you can continue anticoagulating the patient with warfarin at that time if it's indicated. It's important to know if the patient was diagnosed with HIT while they were on warfarin, that the patient should be reversed with vitamin K. Again, HIT is inducing a state of hypercoagulability, and so the warfarin might be contributing to that as well. When looking at the ACCP guidelines for the treatment of HIT, they recommend either argatroban or bivalirudin. Argatroban is the only agent that is FDA approved for the treatment of HIT, so often used in our critically ill patients. And bivalirudin is approved for patients with HIT that are undergoing percutaneous coronary intervention. Now, additionally, dinaparoid and also leparudin are also approved agents. However, they're not available in the United States. There is some data, although limited, with the use of desirudin and fondaparinux for the treatment of HIT. In the small trials that are published, it appears that these agents may be safe and effective. However, again, the larger clinical trials are mainly with argatroban. There are a number of studies that have demonstrated that lower argatroban and bivalirudin dosing may be really prudent to think about in our ICU patients. When you are wanting to maintain therapeutic anticoagulation with these patients, they oftentimes require a 16th to sometimes a 4th of the dose. And so taking that in mind and not using just the package insert doses, but taking in the multi-organ system failure into account and the decreased elimination of both of these agents. So our next patient case is a 55-year-old man with a medical history of DVT 2 months ago, secondary to trauma, and is admitted into the ICU for acute respiratory failure from influenza virus. Pertinent laboratory values, his platelet count is 250,000, BUN and serum creatinine are close to baseline, and AST, ALT are within normal limits. He's on appropriate antibiotics, an insulin infusion, stress ulcer prophylaxis, and DVT prophylaxis. 5 days later, it's noted that his platelet count has decreased to 112,000. His BUN and serum creatinine have increased respectively. And the clinical diagnosis of HIT is made, and your team sent off a heparin platelet factor 4 immunoassay, but you know the results will not come back for 48 hours. So in this case, what would be the best course of action? To discontinue the heparin infusion and initiate argatroban, do nothing because the patient has several other reasons to be thrombocytopenic, discontinue the heparin infusion, initiate fondaparinux, or do nothing until the laboratory results come back. Excellent. So at this point, the timing is a little early, but it's still within that 5 days of seeing the platelets drop. This patient had a history of DVT, so most likely was exposed to heparin within that 2 months, so may have likely developed antibodies. I think you have a good reason to clinically suspect HIT here, and so the first treatment that you would want to initiate is discontinuing heparin and then using alternative anticoagulation. And if you were very astute, the starting dose generally of argatroban is around 2 micrograms per kilogram per minute. So the answer here, if you have good test-taking skills, is about a quarter of that dose, which would be appropriate for this critically ill patient. For those of you who said that the patient has other risk factors for thrombocytopenia, I completely agree, and that's partly why it's so hard to diagnose HIT in these patients. However, because, again, that patient probably had exposure to heparin, the platelet count dropped within 5 days, I think you have to clinically suspect that in this case. In terms of those of you who picked fondaparinux, as noted, the patient had acute kidney injury, so that might not be the best option at this time. And then finally, talking about end-of-life considerations. So when we're dealing with these patients, we want to prevent any uncomfortable or unnecessary procedures, tests, or treatments. We want to minimize as much as possible. We don't need to do routine vital signs, weights, any type of monitoring, finger sticks, or even taking off the DVT prophylaxis because those compression devices are going off every couple minutes. Thinking about discontinuing routine blood draws and other diagnostic procedures, and getting rid of any medications that are not providing that patient comfort. So this is in direct opposition to the shock lecture that you just had, where we're monitoring. These types of patients, once you have those goals of care discussions with the patients, we want to start minimizing and pulling back to provide comfort to the patient, and also to provide some sort of comfort to the family members around as well. So the first thing we want to think about is symptom management is pain. Opiates are the mainstay of treatment, and morphine is commonly used. In this case, it's as long as the patient has some sort of IV access, it's going to be best to give IV continuous infusions, staying away from IM or sub-Q injections. Again, that might just create more pain in those patients. Recognizing that tolerance may develop over time, and making sure that the team members that you're working with don't fear going up on the dose, because oftentimes clinicians feel I'm going to cause more respiratory depression and I'm going to hasten death. However, there are 2 trials that demonstrate that you can appropriately manage pain, go up on the dose appropriately, and you do not cause that increased respiratory depression or hasten death. treating anxiety, agitation, and delirium, using the family who's at the bedside to keep talking to the patient, and getting rid of any extra bothersome noise or other environmental factors. In this case, IV haloperidol works very nicely in these patients, but also remembering you don't have to do routine EKG monitoring. You can just give them the IV haloperidol. And benzos are good alternatives also. Controlling fevers in these patients, so round-the-clock acetaminophen or even nonsteroidals, regardless of the patient's renal function. And even high doses of dexamethasone can help control some fevers as well. Identifying causes for nausea and vomiting in these patients, and then considering the use of agents. So again, haloperidol, metoclopramide, ondansetron, all of that in our normal critically ill patient, we might get a little jumpy and want EKG monitoring. We don't have to do that in these patients. Oftentimes, these patients will have cough, but they're already on an opiate to help that cough. So adding an additional opiate is not going to have any increased advantage. So here, thinking about adding non-opiate antitussives. And finally, controlling secretions in these patients. If secretions are confined to the mouth, light suctioning may be okay, but oftentimes those secretions are very deep, and we don't want to do that deep suctioning. It's going to be traumatic for the family to watch. It's also going to be uncomfortable for the patient. So in this case, using anticholinergics or antimuscarinics. Our options, we can use glycopyrrolate IV, although probably many institutions have some sort of restrictions because of the cost. So you can also alternatively use sublingual atropine eye drops to control secretions as well. If you feel like secretions are going to be problematic for a longer period of time, you can add on a scopolamine patch, but recognize that if secretions are currently the problem, that scopolamine patch won't get into effect for about 12 hours, so ensuring you have something that's going to work more immediate while the scopolamine patch kicks in. And so our last patient case before your break is an 88-year-old woman who is admitted to the ICU for decompensated heart failure and acute kidney injury. This is her fourth admission to the ICU in the past 5 months. You talk to the patient and you see that she wishes not to be resuscitated or intubated, but to be comfortable, and all family members agree, and they do not want to see her suffer any longer. So it is decided to initiate a morphine infusion at 2 milligrams an hour with titration parameters to go up by bolus dosing equivalent to the current rate and increasing the infusion by 25% for comfort. However, the nurse taking care of the patient believes that the titration parameters are too aggressive. So what would be the most appropriate change to make at this point? Your first option is to change the parameters, so only to go up on the morphine when the patient exhibits signs of discomfort, such as an increase in blood pressure or heart rate. Next, you could discontinue those titration parameters and just keep it at a set morphine rate. Discontinue the titration parameters, keep the morphine infusion at the current rate, and add a midazolam infusion, or do not change the titration parameters at this time. Oh, wow, we have a little 50-50 split here. So the answer that I had intended for everybody to pick was not changing the titration parameters. Again, there is evidence to suggest that controlling pain and going up on the infusion will help the patients control the pain and not hasten death. For those of you who thought perhaps to change the parameters only when the patient exhibits signs of discomfort is really taking a reactive approach to these patients at their end-of-life care, and we want to really stay on top of that. So we don't want them to have an increase in blood pressure or heart rate, and we want to ensure that that stays at a steady level.